Good morning, everyone. This is Kathy Bush, and welcome to our DandleLION Medical webinar to Serve, Protect, and Treat 2 Neonatal Skincare Challenges. We're very happy to have with us this morning Medea Esser as our faculty presenter. Medea is a neonatal nurse practitioner at Children's Hospital of Wisconsin. She is pursuing her PhD and is also a fellow in the Sigma Theta Tau Maternal Child Health Leadership Academy. She has served as president of the National Association of Neonatal Nurses chapter of Southern Wisconsin and has presented at several local and national conferences in the last year about her work in skincare. Medea is passionate about neonatal skincare, and she's worked on streamlining care with the development of a diaper dermatitis algorithm. Her expertise has also been integral in the development of a NICU skincare policy revision. She plans to continue her work with skincare by developing a pilot study for her dissertation that will look more closely at skin injuries. Medea, welcome, and thanks for being with us this morning.
Thank you, Kathy. I'm happy to be here. I'm really excited to share all of these things that I've been doing with skincare with all these wonderful people all over the United States. I hope everybody's staying warm. My husband's outside snow blowing all the snow we got yesterday. So here we go. I want to talk about 2 skincare challenges that are very near and dear to my heart. First is diaper dermatitis, and second is neonatal wounds. Become very much more involved in the understanding of skin injuries, and these 2 things have kind of jump-started that for me. So my disclosure slide is that I have nothing to discuss. We'll be talking about products by name, but I do not work for any of these products, nor do I think you must go and get them as much as I love them. The objectives today are the same as were outlined on the advertisement. I want everyone to be able to discuss at least one benefit of using an algorithm to prevent, identify, and treat diaper dermatitis in the NICU, or the Neonatal Intensive Care Unit. List 2 skin injuries that could benefit from hydrogel dressings. I'm going to give you a few more than 2. Summarize the current body of evidence presented that's supporting the goal of early identification and treatment of challenging skincare issues in the NICU. So let's start out with diaper dermatitis. As I said, this is very near and dear to my heart. I found it to be one of the more frustrating issues we come across as nurses, especially in the NICU. So let's review the causes of diaper dermatitis. Many of us probably already know this, but I want to just do a quick review. Diaper dermatitis is said to be caused by the overhydration of the skin, which can increase the pH. Now, that elevated pH will affect the flora of our skin. The stool and the urine cause that pH to become more alkaline, and the acidic barrier of the skin is then compromised and unable to protect from the invasion of other harmful things. Then the friction from the diapers or the wiping causes the redness and the breakdown, and this cycle just continues. So I think most of us are familiar with the signs of diaper dermatitis: the erythema, the edema, the blistering, erosion, and weeping that we see, and the pain that comes along with it. So there is a lot of supporting evidence out there. Most of them are review articles. There are few randomized control studies out there, and then there are many poster presentations. And I want to discuss just a few of the review articles and poster presentations that I've. The first one I want to talk about is an article by Shin in 2005. It was a review article that talked about how half of all infants that visit the pediatrician's office will have diaper dermatitis, which is really outstanding to me. When I think about the babies that we take care of in the NICU, they're going to go to the pediatrician, and I wonder how many of those are from the NICU. But anyways, she talks about how friction is a major factor. Microbes do not play a major role, as I think a lot of people think when they see that breakdown. Breastfed infants have less diaper dermatitis, and it's mostly due to the breast milk that they're getting and how that changes the pH of the stool. Common sense is that there's less diaper dermatitis with the more diaper changes that you do, and that cleansing can be useful. Some of the treatments she mentioned were baby wipes, and how at the time in 2005, a lot of the baby wipe manufacturers recommended the discontinuation of the wipes when the skin is broken. Now, I've looked at some of the wipes nowadays, and I don't see that warning anymore, but the ingredients have also changed on a lot of those products. She also found barriers are useful in protecting the skin. Powders have been seen as helpful, but we have to be careful of the ingredients in the powders. There shouldn't be any talc, boric acid, or baking soda. And a lot of the powders have now come away from those ingredients, but it's very important to make sure that those aren't included in the powders that you're using if you choose to use them. She also mentioned how no prescriptions have been proven to treat diaper dermatitis, except for Nystatin, of course. Another article that was helpful was one by Ratcliffe, and it talked about how the worry over increased costs related to how many products that are being used at the bedside and in the basic care of diaper dermatitis affects the treatment practices. So she looked at using one product on 5 neonates and found that there was a reduction in erythema over the 24 hours in the consistency of that care. She continued to use that product prophylactically until discharge. Another article by Derev discussed all of the differential diagnoses that can come up with diaper dermatitis. And he found that diaper dermatitis is the most common dermatologic finding in infants. And he validated the idea of how important prevention can be in fighting this phenomenon. So skin hygiene, preserving the barrier, preventing the friction, some of those things I showed you on that cycle on the first slide. Barrier products are helpful. He did not discuss the consistency in care, but the one important message in this article was how further investigation needs to be thought of when you come across a diaper dermatitis that is so chronic that everything that you've done, the consistency, the treatment, the interventions, and it's just not getting better. It may be time to advance to a dermatology consult. So the bottom line in most of the evidence that I've found is that we're preserving that bottom line, providing preventative measures and barrier protection. So I want to talk about 2 of the main ingredients that most of us see in the diaper creams that are out there and the barrier creams. Zinc oxide is one of the more important ingredients. It is a white powder that is suspended in a cream or an ointment. It is very helpful in repelling the fluid. It's not absorbed into the skin, and it has antibacterial, antiseptic, and astringent properties. I think one of the most misconceptions out there is that zinc oxide can be absorbed into that broken down skin, and that is not true. It's all about how the powder is made up. So there are things called nanoparticles. Now those are where you should be concerned about it being absorbed into the skin. And most of the diaper barrier creams that I've found out there do not have zinc oxide nanoparticles. So this should not be something to be concerned about with the use of zinc oxide. The next ingredient would be petrolatum. And that's another main ingredient commonly found in barrier creams and any sort of diaper rash product. It's been found to be very supportive in aiding the enhancement of the skin barrier by its ability to travel into the interstitial spaces of that stratum corneum and aid in the barrier recovery. It's all about these fatty acids that are contained in the petrolatum, and the combination products that are available help work together with the zinc oxide and all of the other ingredients to assist in the accelerated repair of that affected skin that you're trying to treat. And that's why it's such a great partner with zinc oxide. One protects and one promotes the skin integrity and condition while repelling fluids and providing that barrier with those antiseptic properties. So there are things to watch out for when we're looking at choosing barrier products or any products for diaper dermatitis or any type of skincare. The fragrances, the preservatives, and the additives that are in the ingredient list, most commonly found in the inactive ingredient list, can be harmful. They can cause sensitivity reactions. They can cause issues down the road. So be careful. It's good to learn about these ingredients before you begin to use them. So now I want to talk about some of the hospital studies that I came across. And this one was done at St. Elizabeth's Hospital, which is here in Wisconsin. It was actually a poster done to discuss the using Sensicare on 4 different types of patients, all of which these patients have huge risk factors for developing diaper dermatitis. There's a neonatal abstinence syndrome baby, there's a baby on antibiotic therapy, one with caustic stool, and then another one with increased gastric enzymes. And they found that the use of Sensicare improved their diaper dermatitis over time. They also mentioned the use of Vaseline and sensitive wipes with their care. This study by Heimel and her partners called Beginning at the Bottom, Evidence-Based Care of Diaper Dermatitis is one of my favorite articles. If you are working on developing practice change in skincare or the development of a diaper dermatitis algorithm, I strongly influence you to read this and use this as one of your big references. She talks about the consistency in practice that is needed in the development of a diaper dermatitis algorithm. She found that her prevalence rate of diaper dermatitis was 24% before she started, and it was decreased to 11% over a 2-year period with the use of this algorithm. She promoted prevention with Vaseline and triple paste and Nystatin. She has a really beautiful algorithm with pictures, and it's actually included in the A1 skincare guidelines. And this was a huge basis for my work with my algorithm. So some of the common themes that I found in searching through the evidence was how they treated the different stages, should I say, of diaper dermatitis. The erythema with the intact skin was most often seen with the treatment of zinc oxide cream or paste. Now, once we got to denuded skin, they used zinc oxide or a stoma adhesive powder or Ilex, and some of the articles discuss the use of a crusting technique. So there is a variation across practice for the broken down skin. And then one of the commonalities I found was they all treated with an antifungal for candida or a yeast diaper rash, which makes sense. And here's my algorithm. Now, I know it's difficult to read. I tried my hardest to get this to be readable in a PowerPoint slide, but it's hard. So if this is something that you're interested in seeing, I'm happy to share it with anyone who wants it, and my contact information will be at the end of the presentation. Just email me and I'll send it to you. So the basics of my algorithm is I really wanted people to see the flow of the algorithm and how the arrows go and how simple it can be. So I chose this algorithm to be for the hospitalized infant with diaper dermatitis because the products I use are most often found in the hospital, although you can find many things on Amazon nowadays. But the top of my algorithm describes the use, in the first box, the use of baby wipes, gentle baby wipes, or barrier wipes if you have those in your institution, with Vaseline or petroleum jelly, and using those prophylactically so that we're doing a piece of prevention in caring for our infants at highest risk for diaper dermatitis. It also discusses the daily, what we coined as butt baths for every infant. And it also discusses in that next box a thorough assessment of the diaper area using a skin condition scale, as well as an assessment of the risk factors for each infant. So on the left-hand side, that's where we talk about candida and the need for Nystatin ointment. And I just want to plug here the importance of ordering ointment versus cream. Ointment penetrates the stratum corneum that much more, and it gets that medicine to where it needs to go. So as a nurse, as a provider, please try to order the ointment instead of the cream. I think the misconception is that the cream spreads, it's like a lotion, it absorbs into the skin, but it doesn't. There are many studies that show that the ointment penetrates that stratum corneum to get the medicine where it needs to be in just a more effective way. So now on the right-hand side is where we discuss the general infant diaper dermatitis with some erythema. So what we do, as soon as we see redness, we apply Sensicare, and we continue those butt baths, we continue the barrier wipes, and we continue to use the Sensicare for at least 3 days. And so my rule of thumb is you use any product for 3 days before you decide to change it. You have to give it a chance to work. And so that is one of the harder things to kind of tackle for a lot of nurses that want to change it. You know, oh, I know this product works really great and I want to change it to this. But you have to give the product that you started with a good chance of 3 days. So if after 3 days it's worse, especially if it's bleeding, then we move on to Ilex. And Ilex is very helpful, and I'm going to discuss these two products in the following slides. But Ilex is very helpful. It's our last line of defense. We don't often get there anymore since we've developed this algorithm and a better process of managing diaper dermatitis. And then down at the bottom left-hand corner, that hexagon is for when we have Ilex on back. Happens pretty often, and it's on back order right now. So that box discusses the use of stoma adhesive powder in correlation with Sensicare. So moving on to the next slide, I want to talk about those products just a little bit more. And I want to remind everybody that there are a variety of products out there, and I am only discussing the products that we had available in our hospital that I found helpful. But in your unit, you may have other products that you really love and that work just as great as these products that I'm presenting to you. So I urge you to investigate and try and streamline your products down to the ones that actually work, that are consensus within your unit. So Sensicare and Ilex are similar but different in that they are both a petrolatum base. They both have zinc oxide. Ilex doesn't disclose how much zinc they have in it. They both stick really well to the skin, and they both can be used in combination with other treatments such as Nystatin. Ilex adheres to wet, weepy, really denuded, bleedy skin really well. It provides this wonderful barrier for the skin to kind of heal underneath. So when we do our butt baths, we try to get off as much of the cream as we can, but we don't remove the stuff that doesn't want to come off. Because if it's being stubborn, that means it's there for a reason and it's truly doing what it's meant to do, and that is protect the skin. Another key thing about Ilex is it needs to have Vaseline over it to protect it from sticking to anything else that comes in contact with it. For example, the diaper. Oh, excuse me. So it's important to have that Vaseline ordered in combination with Ilex. And so in talking about the Vaseline and the Ilex, I really wanted to provide everyone this example that one of my wonderful nurses that I work with provided me. We originally wanted to do a video of how to apply Ilex in combination with Nystatin, but she did a sort of a slideshow for me instead, which is just as effective. So on the right-hand corner, up at the top, you see the diaper. So the very first thing that she would do is coat the diaper in Vaseline. And actually it works very well. You coat it with Vaseline, you put it on the side so you can just grab it at the end. So that next picture is after cleansing, and we're assessing the area and looking at, yes, we still need to use Nystatin. Yes, it's still very broken down and we need to continue to use the Ilex. So down in the left-hand corner at the bottom is the application of the Nystatin. And so she uses a Q-tip. She literally applies that Nystatin, lets it kind of set for, I think she said like 30 to 60 seconds. And then she applies the Ilex in a very thick coat and lets that set. And what's funny is I say set, and it truly does. It changes the way it looks in a matter of 30 to 60 seconds. And then we pop that diaper on and the baby's good to go. So now what do we do in between diaper changes? So we will do this whole process with the butt bath, which generally you only need to do once a day. But some nurses really, really want to assess that skin. And so doing it twice a day, Q12, is okay, as long as you're not removing all of the product to damage that skin even more. So in between diaper changes, what we do is we change the diaper. There's going to be stool there. And we just blot off the stool and we reapply the Ilex, coat that diaper again with Vaseline, and pop the diaper back on. Now, I think the hard thing to get over is how gross it's going to be. And that's okay. You know, the stool isn't getting to the skin. It's only sitting on top of the cream. So if you get enough cream on there, it won't get to the skin and give that thought of, how gross is this? Why aren't we removing it completely? The other thing is I change practice in the units I work in to apply the Nystatin with those butt baths. And I think the thought out there is that it needs to be applied 4 times a day, but truly that Nystatin is staying on there longer if you do it right after the butt bath and you keep that barrier cream on there. So that is why I change the practice to twice a day if it's this severe, because then it makes less work for the nurses to have to kind of get all that cream off and apply the Nystatin when they could possibly be doing more harm than good in removing all the cream. So overcoming all these barriers that I've talked about, we've gone through the basics, talked about the literature, we've discussed my algorithm, we've discussed the products, we've just discussed the usage. So now what do? We have to overcome the barriers. So where are the barriers? Are they insufficient access to products? Are they the breakdown in consistency? Is there a lack of knowledge about the products? Is there a lack of adherence to the treatment regimens that are laid out? And where is the follow-up? And we see these in all sort of situations, not just diaper dermatitis. So I wanted to provide sort of a quick and dirty of how to implement some change. Now, some people may follow guidelines of an evidence-based practice protocol. This is a perfect opportunity or example to use for an evidence-based practice project. But in all simplicity and generalizability, we need to define the problem. We need to get the staff involved. We need to get some education out there, and we need to make sure there's follow-up and follow-through. So in defining the problem, we need to decide how big is the problem. Is it just diaper dermatitis, or is it that you need a whole skincare policy revised or created? So is there lack of consistency in practice? Is it there's too many products and you need to streamline it? Is there a lack of knowledge surrounding the products and its usage, or is it all of them? And then how do we get the staff involved? We want to promote success. In achieving success and practice change, you get the staff involved, and that will help move things forward. So things like surveys, brown bag lunches, staff meetings, bringing up ideas, bringing them into how do we change practice, and creating groups, skincare teams, initiatives, things like that. And then the education, as we all know, is important. Everybody needs to know how to use the products, what they're for, what are we doing this for, and then the follow-through. Now, having skincare champions and skincare groups help in supporting the staff through troubleshooting problems, and they help provide consistency between caregivers. So I wanted to share my surveys that I sent out to the unit I was working in, and this was part of my master's program as I worked towards revising the skincare policy for the unit I was working in. And as you can see, I asked the nurses to tell me what were the skin issues that they most oftenly saw, and how many times did they reference the skincare policy, because I thought those kind of went hand in hand. So what is the skincare issue that they found most often? It was diaper dermatitis, and then dry skin. So what I need everyone to know is that we didn't have a preventative sort of initiative or treatment plan that was well laid out in our skincare policy at the time. There was a lot of great information in our skincare policy, but it was a very lengthy policy. And so as you can see, they rarely, if ever, referenced the policy, which could be very frustrating when you come across, oh, well, there's this diaper rash, and that's your most often encountered problem. And in the skincare policy, it tells us how to treat it, but you're not going to it. So it's important to find out what issues are the most prevalent in your unit, and how frustrated are nurses about them, and are they looking at the skincare policy. So looking at these two surveys, it showed me that I needed to change the policy in a way that it was easy to reference. So if people knew, oh, there's an algorithm, I can just click on that, print it, and put it at the bedside, that would be the easiest thing, instead of trying to read through all of the wonderful information that was in there. So as we all know, change is difficult, and I found this to be problematic as well. I had many positive supporters throughout this journey of skincare, and I still do. But then there are always those people that just can't support what you're doing. And so my survey kind of showed the true colors of some of the people I was working with. And some of the negative comments that I've heard in all my years in working with diaper dermatitis have been really eye-opening. Things like a nurse can think through her own way of doing this. Why do we need an algorithm? Or this is ridiculous. It's just common sense. Why do we need this? It's extra work. Why do we need to make more work for ourselves? And so I think it's obvious that, if this wasn't a problem, I wouldn't be doing this. And so what I learned in trying to help bring those negatives to a positive was showing them how my work was changing the care we provided for these infants. And I had a great group of nurses help me on this one baby we had on the step-down unit who had short gut and was stooling very often, had a horrible diaper rash that was bleeding. And I said, let's try Ilex. No one had ever heard of it before. I created a care plan for the bedside with instructions on how to do it. And I had a good group of nurses that took it and wanted to run with it. And so we took pictures of the process all the way through to healing. And so it was a good experience. The nurses had fun with it. And they actually washed and did butt baths a little more often than I'm recommending, but it was because they were seeing a change and they saw a positive change and they wanted to share it with everyone. And the biggest takeaway from that whole situation was it was the right time to do it because our medical director was actually the attending on the floor that week. And he got to see what this product did and what the consistency in practice did and how this related to the algorithm I had been talking to him about for so long. So that support really jump-started a lot of my work and promotion of the algorithm into the unit. So how do you achieve success in your units, and how do you define success? So we all need to promote the adherence of treatment regimens. We have to enhance the awareness about the issues and about how to treat them and how it can actually work. We increase the proactive prevention strategies, we roll out education, we use the tools that are available to us in the hospital, and we create a skincare team. And that all results in a reduction of the rates of skincare issues for our very delicate and fragile patients. I see hardly any babies with bleeding diaper rash anymore because of all the work that all the wonderful nurses I work with have done in preventing it. Every baby that comes into the unit gets Vaseline ordered and it's put on their butts from day one until you see a little bit of redness, and then they go to Sensicare. It's a wonderful thing to see a project go from so little to such a great impact on these patients. So I just want to share this little cartoon with everyone. We all know change is inevitable, and isn't that a good thing? So I want to move on to the second part of my talk about neonatal wounds. And I want to preface this with, I am not a wound care ostomy nurse. Maybe one day I will be when I finish my PhD, but right now I am speaking to all of the things I've learned and done in my practice with skincare. A lot of the misconceptions are that neonatal wounds aren't as common as adult wounds, and wounds in many people's minds are, those gross, gangrene, adult sort of diabetic wounds, and how could those be in a neonatal patient? And I'm here to share with you that they happen, and they happen in all kinds of our patients. My experiences with wounds and hydrogel dressings have been very eye-opening and positive. And so I know that some units may be familiar with hydrogel in the use with IV infiltrates. And some units, and ours does this, is if there's a really bad IV infiltrate, we use hyaluronidase injections, and then we put the extremity in a hydrogel boot, which is just most of the time a U-bag cut and filled with hydrogel. And we leave that on for 24 hours, and it helps promote the pulling of all of that infiltrated fluid out of the extremity to heal it faster. And then we continue to redress it for how many days that it needs to be. So I'm going to give you a brief background on wounds as I understand them and what I've done with hydrogel dressings to treat our neonatal population. So first I want to talk about the phases of wound healing. There are 3 phases: inflammatory, proliferative, and maturation phases. Inflammatory, being the first one, occurs just after the injury happens. It gives that erythematous, swollen appearance and sometimes warm to touch sensation. It's important to not prolong this phase of wound healing by creating further trauma with inappropriate dressings or wound care practices that don't promote healing. And so I've seen in this phase is the misconception that we need to dry out a wound, or I've seen some doctors order betadine washes frequently to sort of cleanse the area and clean it out and make sure it dries out to promote healing. So then that leads us into the proliferative stage, which is when the granulation tissue is beginning to form and regeneration is starting. And during this phase, new blood supplies are being created, and they're promoting the creation of an epithelium. The edges begin to pull together, and the scar tissue is beginning to form. This phase is enhanced with the provision of a clean, moist, and protected wound bed. If the wound bed is not kept moist, that epithelialization is prolonged, and the risk of worsening scar tissue occurs. And then finally, in our maturation stage, this is the remodeling phase. It's when there's continued formation of collagen and changing shape of that wound bed. The wound is becoming stronger, and the skin is beginning to contract and improve its strength around that affected area. So that healed wound, just a couple more things about the healed wound. It has decreased strength, and it's never going to be back to that strength it was before the injury occurred. So it's continually at risk for injury. And it's important to monitor these areas very closely because they continue to be at risk for breakdown. So let me talk about hydrogel. There are many different forms of hydrogel on the market. I am simply providing you with the 2 or 3 that I'm familiar with in my practice, but if you Google hydrogel, you come up with so many different kinds, and you may be familiar with different ones than these. So hydrogel can be in an amorphous form, in sheets, or in a fluid, or a gel, or a tube, as you see in the pictures. It's made up of humectants and water. The main ingredients are typically humectants, which come in differing concentrations, and those humectants attract and hold and bind the water to itself or the product in the case of wound healing. These are usually represented by various polymers available in the general market, such as propylene glycol, which is actually in the Intrasite gel that you see here. And the higher the concentration of these materials, the more exudate that it will pull from the wound to promote that healing. And it's also been shown that the higher concentrations have been proven to be have bacteriostatic properties. So just more about its product information. It provides moist wound healing. It provides rehydration. It has a balanced gel formulation with those ingredients to benefit the wound. Its most important method of action is its ability to provide the autolytic debridement of the wound. And so autolytic debridement, what's that? Autolysis uses the body's own enzymes and moisture to rehydrate, soften, and liquefy hard eschar or slough. Autolytic debridement is very selective. Only necrotic tissue is liquefied. It's also virtually painless, which is one of the benefits of using hydrogel. Autolytic debridement can be achieved with the use of occlusive or semi-occlusive dressings, which maintain wound fluid in contact with that necrotic tissue to help those enzymes kind of break it down. Autolytic debridement can also be achieved with hydrocolloids, hydrogels, and transparent films, which is what I'm talking about. So the best times to use it is with those stage 3 or 4 wounds with some of that light to moderate exudate. And the advantages it provides is that it damages the surrounding skin. You will see some maceration of the tissue sometimes with the use of hydrogel dressings, but it doesn't damage the skin. It's just kind of hydrating it to look like you've been in the tub too long. You know how your fingers get pruny? The process is safe. It uses the body's own defense mechanisms to clean the wound of the necrotic debris. It's effective, it's very versatile, and it's easy to do. Some of the disadvantages are that it's not as fast as a surgical debridement, but it keeps that patient from having to go through a surgical debridement. And what does that entail? You know, there may be anesthesia, there may be, intubation. There are lots of risk factors associated with that. So if we can avoid that for some time and still heal the skin while not prolonging hospital stay, it may be beneficial. And we need to monitor the wound very closely for signs and symptoms of infection. So now we're going to get to the fun part. Some of the examples of the neonatal wounds that I found hydrogel to be helpful for are congenital wound that I came across, a birth trauma case that I came across, a post-op surgical site, and an in utero injury. The first one is this congenital skin injury that was transferred to our hospital from one of the outside, more community hospitals. So this was a term infant that was delivered with little or no prenatal care. We suspected that it was a compression injury. And as you can see on the underside of the forearm, there's a chunk of skin missing there. On the top of the forearm, there's a chunk missing. And the hand is beginning to show signs of perfusion problems. It's purple, the nail beds are purple. And so this baby stayed at their hospital for the first 5 days of life. And they did Mepilex and antibacterial ointment or antibiotic ointment to the area. So this is what it looked like when it came to us. And you can see the palm is fluffing the tissue. The wound is starting to dry out and form eschar. On the right-hand picture, you see really close to the edge there, that black area. That is eschar. And then the yellow on top of the hand and right above the black area is eschar starting to form. So what did we do with this? We've consulted plastics. Surgery was also involved, but neither one really had anything major to offer. So what we did was we did a hydrogel dressing. So this patient had dressing changes, I think, every 12 hours in the beginning, and we backed off to every 24 hours for a little while, and then every 3 days. So with every dressing change, we gave this patient some morphine, pain medication, and he got sweeties throughout the whole procedure. The wound was cleansed first with saline. We never used soap and water on this patient's arm. We also looked for we used a Doppler for the pulses, and we found the Palmar pulses, the radial pulses, and the ulnar pulses, all to be present throughout the whole treatment phase with hydrogel. So we first applied the hydrogel after cleansing, the intrasite gel. We squeezed it onto the area, and then we applied a sheet of hydrogel, as I showed you in that slide of all the hydrogels. And then on top of that, we covered it with Telfa, because we didn't want a gauze that was going to stick and absorb the hydrogel away from the wound. So Telfa made the most sense. And then we took the Telfa and we put it between the fingers to help separate the fingers and protect the skin of the fingers, and wrapped it all in gauze. Now, we involved the parents. The grandmother actually assisted with, holding and giving the pacifier during several of the dressing changes. And then day of life 22, this is how much that skin has improved. And so you can see the underside on the left-hand picture of that whole arm was starting to granulate, and the tissue was starting to look more healthy. The skin is pinker. The fingertips are still necrotic and a little bit swollen. And then you see on the right-hand side that eschar, how it shrunk tremendously. That area right above the elbow had shrunk in half. It had reduced its size by half, and the black that was there had now disappeared into the yellow. So we softened that area and shrunk it. And that top area on the hand was starting to shrink and lift up slightly. And so what is interesting to find is that hydrogel will start to heal from underneath. And so that's what was going on here. It was shrinking that eschar and sort of getting up underneath there. And the problem plastics had with this was it was day of life 22. The baby was in the hospital, ad-lib feeding, gaining weight. There was no reason to keep this baby in the hospital any longer. But there were social situations that prevented the baby from going home with dressing changes. And home health nurses weren't able to visit the house and support the dressing changes with the family frequent enough. So plastics decided to take him for a skin graft. And they grafted both areas on top. And this is the picture that I have a few weeks after the skin graft. And so it was reported that the skin graft at the top of the hand had taken fully, and the one down where that black area of eschar, that one did not take hardly at all, is what they had said, because there was so much necrotic tissue. But I mean, it looks pretty good to me. It's unsure if his fingers move yet. They had never moved during the whole process. But the plastic surgeon had mentioned that he would have recovery of movement with therapies. So the next case I have is a late preterm that had several pop-offs of a vacuum during the delivery. This wound is pretty deep, as you can see. On the left-hand side is when I first encountered it. And all this, I was unsure as to what the black was around the area. So I didn't want to remove it. I simply cleansed it with saline, and we washed around the area with soap and water. And then we applied hydrogel inside of the crevice there. And then we placed a Mepilex Border type dressing on top of it to sort of keep in the moisture and promote that healing. And you can see halfway through the treatment, that right-hand picture, it was starting to form tissue and granulate under that bed, and all of that black came off. So the funny story behind this was they have a wound ostomy care nurse on staff at this hospital, but it was close to a weekend and she wasn't there. And we were going to wait until Monday. And I thought, that doesn't seem right to me. Can we find some hydrogel in the hospital, and let's try some hydrogel. At least we can protect the wound and prevent it from getting infected. And so that's exactly what we did. And so I wanted to just show you what Mepilex looks like, since I mentioned it here and I'm going to mention it again. It's a really nice dressing that, for the reasons I like it, is because it doesn't damage the skin with the adhesive that is on the edges of it. And there's a big piece of gauze in the middle to promote that moist wound healing environment. And it's provided by Molineek. You know, I'm not trying to plug the product. I just want you to be aware of what I'm talking about as I talk about my interventions. So this is what it looked like when he was going home. And he went home. There was no hair growth there in the middle where the damage was done. And he may never grow hair there, but at least he has full thickness there of normal skin. Now, as I mentioned before, that skin is not going to have the same strength. They're going to have to continue to be careful with how it's protected and the breakdown that could happen. So next one is a ligation site. So this baby was had a PDA ligation, and I think it was sometime after the ligation where the site started to open up and kind of look like something's going on there. Now it doesn't look infected, it just looks like it's irritated. So we washed this, I believe we washed this with soap and water, and we applied hydrogel, and then we put the Mepilex Border over it. And so what started to happen is the hydrogel would pull this exudate out of there, which you can't see in this picture real well, but there was this yellow that would come out of the wound, and the stitches started to rise to the surface. And so it was kind of creepy because they were hidden stitches, and we ended up pulling all of the stitches, and this was, I think, after all the stitches were pulled, and it was healing really well. So once we got the stitches out, so for whatever reason, the stitches were irritating this whole area. Once we got them out, the wound healing just flew from there. And this is when we discontinued the dressings. And the baby went home, I don't know, several weeks afterwards with the scar looking even better than this upon discharge. So and lastly, I want to talk about an amniotic band baby that came to us from an outside hospital on the day of delivery. It was a 26-weeker who was very sick from a respiratory standpoint and had several banding issues. So these were the lower extremities, but the upper extremities were affected as well, but there was no skin breakdown. So as you can see on the right-hand side, the leg was amputated just above the ankle, and then on the side you see this club foot appearance to the other leg. So what we assumed was that that amputated area was rubbing against the club foot leg. And so we needed to, number one, protect it, and we also needed to treat it. So for this one, we washed it with soap and water because I was unsure if the baby had had a bath, and I didn't really want to have any reason for these wounds to get infected throughout the course. So we washed it with soap and water. This was also a weekend occurrence, and so there was discussion of consulting plastics, and so I had mentioned, can we please just try the hydrogel dressing over the weekend or for the next day or so before we consult plastics. Be it a weekend, you know, it's an extra cost for them possibly to come in, and they're not going to do anything different from the experience I've had with other patients. So we started applying the dressing, just as I've mentioned with all the other dressings. We put on hydrogel, and then the hydrogel sheet, and then Telfa, and then wrapped it in gauze. As you can see here, this baby was very vigorous and very feisty, and he would kick off the amputated extremities dressing so frequently that we decided to use a Band-Aid. And it's those weird Band-Aids that cover the tip of your finger. But what you can't see underneath that Band-Aid is Duoderm, because I wanted to protect that sensitive skin from those terrible adhesives in Band-Aids. So that actually helped us out a lot, and those Band-Aids stayed in place really well through the course of his healing. And then almost exactly to the day, 3 weeks later, we removed the dressing to find a totally healed area on the club foot leg, and the amputated side was healed as well. And so what we ended up doing was putting Aquaphor on foot leg because that area, as I mentioned before, was not as strong of skin as the rest of the leg or the rest of the body. And so our physical therapist people were working with him and doing exercises to keep that skin from tightening and contracting. And they put this Mepiform dressing on there to try and help protect more, and that actually caused a skin tear. So we stopped using that and just continued using Aquaphor with Mepilex dressing, which is just a soft, squishy, protective sort of dressing to continue to protect the area, because that amputated leg continued to rub on that area. And so we needed to just make sure that he had enough protection there. But this is one of the more impressive healing stories I had. So what we need to keep in mind with Hydrogel is that infection eliminates the ability to do the hydrogel dressing. So you cannot initiate a hydrogel sort of protocol or dressing if there is a worry for infection. Some guidelines out there do say you can use hydrogel in collaboration with antibiotic ointment, but I think that you need to do cautiously, especially if you don't have the guidance of a wound ostomy care nurse. We need to continue to monitor that area very closely for infection and have someone familiar with the wound healing process to help guide that whole practice. I do have to say that all of these cases that I mentioned here, none of them developed an infection of the wound. None of them had septic workups except for the amniotic band baby. But that was mostly because he was a 26-weeker. He was very sick in other ways, but none of them related to the wounds that he had from birth. Summing it all up, we talked about prevention, we talked about assessment, we talked about care, intervention, and treatment, and then the plan and follow-up. All four of these circles are very important in any creation of a plan for skin care or any other sort of change project for that matter. Making sure we think of prevention is really important to me. Making sure that we have an assessment piece, we have the proper people doing the assessment, we have the proper tools, we're providing the proper care and the interventions, and we're creating guidelines surrounding the evidence-based nature of our care to bring quality to these very fragile patients that we take care of. And we need to make sure we keep creating new plans and following up with these patients and what we're doing. And lastly, I just want to offer up one resource that's out there that I recently learned about. There is a wound care certification course online and in person. And I just wanted to provide you the website for anyone who's interested. Now, this is different from the wound ostomy care nurse certification. This one's shorter, and it offers a lot of education surrounding just the basics of wound care. It's not neonatal specific, but it's one additional resource for those of you that are interested in furthering your skincare knowledge. And finally, I wanted to provide everybody with the references that I've come across. I have hundreds more, but these are ones that I found most important in developing this presentation. And here's my contact information. I invite anyone to contact me about any of the things I've presented here. I'm more than happy to do any sort of talks for grand rounds or presentations or chapter meetings. Just send me an email and I'm happy to oblige.
Medea, thank you so much. We had so many comments over in the chat area while you were speaking about what a wonderful presentation you gave. So we thank you so much. We do want to take 5 minutes now for questions. So if any of you have questions, please type them in the chat area on the left, and we will feed them to Medea for more answers. There is one right away from Leah Carpenter from Kirkland, Washington. Using hydrogels does cause quite a bit of maceration to surrounding tissues. It's a good idea to use a barrier film like a Cavalon No Sting for infants 30 days and over, or Marathon by Medline for infants 30 days and below. Medea, do you want to comment on that?
I think that's really a very important thing to mention. I was trying to keep my slides quick and brief, but we did use Cavalon, I think, in one of these cases to see if that would help prevent some of that maceration. It's also helpful to slim down the dressing size too and try and just focus on the area that is affected. We've also seen when we do this for IV infiltrates, we sometimes will create a duoderm with a hole in it so that it sort of protects that skin from getting macerated. But also just keeping a close eye on this maceration is very important. Thank you. That was a great comment.
Any more questions? Here we go. What type of soap is used when cleaning the wounds?
That's a very tricky question. So what we do use is whatever is available in the unit. So in one of the units, it was a Johnson & Johnson baby product cleansing. Another one, I think it was Physoderm baby. It's whatever I had available. And so for the ones I mentioned that I didn't cleanse with soap, it was mostly because I didn't want the that sort of product in the wound.
Another question, what exactly is a butt bath?
That's a really great question as well. It's really just sticking their butts in a tub, sort of like a sitz bath, and washing it with soap and water, and not causing a lot of friction when you're washing with the soap and water. Or if they can't sit in the tub because they're too thick or too mobile or whatever it may be, is just taking some very soft cloths with a lot of soap and washing with soap and water and rinsing. It's just as simple as that.
Okay, no other questions coming in. Oh, here's another one. Do you have any misgivings about any of the chemicals in the products that are being used?
That's a difficult question for me to answer. I have found that it's important to read the ingredients. I may not know what all of the chemicals are, but I think that speaks to how important it is to read the labels and compare it to products that may not have those ingredients and see if they're just as effective.
Okay, last chance on questions. Oh, here we go. Is Ilex recommended for premature babies or just full term?
I have used it in both. From what I can understand the ingredients to be, I feel like it's a safe product to use on any child in our unit. And we've used it for ostomy sites as well. I didn't dive into that because that's more of the wounded care ostomy nurse realm, but it has been found to be very useful in those babies. And a lot of times those are the premature babies. So I think it's pretty safe.
Is baby oil as effective as petrolatum?
To be honest, I haven't investigated baby oil as much as petrolatum. And so I would have to defer that question to maybe talk offline.
Okay. Next one. Could you clarify the use of Cavalon versus Marathon by Bedline?
I think you need to read the instructions for both of them. I'm familiar with both products, but they're two very different products, and the makeup of both of them is very different. I do not personally see Marathon in either of the clinical sites that I work, so it's difficult for me to speak as an expert on that.
We do have a comment as well that another hospital uses Ilex on all babies of any age. And another one, we prefer plain mineral oil versus baby oil in peds derm in an effort to avoid fragrance. Okay, I think that's the end of the questions. Again, so appreciate Medea's great information. This webinar was brought to you by DandleLION Medical, and we are thrilled to have experts like Medea as part of our webinar series. Medea, as she mentioned to you, does not have any affiliation with DandleLION Medical, but coincidentally, we have just started offering a brand new diaper rash barrier that uses zinc oxide that's called Nurturing Balm. And the benefits of Nurturing Balm are that the additional carrier ingredients are all organic and they're free from harsher toxic chemicals. They have no fragrance, none of the things that you want to avoid in baby skin care. There is a place on the evaluation form to note that if you're interested in receiving some free samples of the Nurturing Balm, along with more information about the importance of organic skin care products for babies, we'd be glad to send you some. In order to receive your free CE, you need to fill out the webinar evaluation. In the chat area, you'll see that you can just click directly on that evaluation link, or once we're finished, you'll be immediately redirected to the evaluation form if your firewall allows. At the end of the evaluation form, you'll receive a link to the CE certificate. If you don't have time to fill out the evaluation right now or your hospital is blocked access, you will receive an email within the next few hours with a link to the evaluation as well as a link to the recording, a PDF of the slides, and hopefully we'll be able to put Medea's algorithm right up there too, so you can get that just by, clicking on the link that you're going to get from us for the recording. Please note that if you are viewing as a group, you must each log into the evaluation in order to be able to download the CE certificate. We hope that you'll visit DandleLION Medical website for future webinars, and also we have links to the recording of now 23 previous webinars that have been recorded and are active and still available for continuing education credits. So we hope you all have a great weekend, everyone. Thanks so much for participating, and thanks again to Medea for a great DandleLION webinar.
Thank you.